Assalamu alaikum everyone. I hope you're all doing great. My name is Zahra Alkatmah. I'm a fourth year medical student and today we'll be talking all about cerebrum and the blood supply of the brain. Before I start, I want to give a little quick disclaimer. Since these lectures are very anatomy based, um, they are generally purely memorization and I might sound throughout the lecture like I'm just reading off slides but I'll try my best to explain as much as I can and I've included so many pictures as I want you guys to understand them visually so you are able to memorize them best. Um since this is a recorded session, please, if you have any questions, please do not um hesitate to contact me on my number or my email. I'm always one message away or one email away. So yeah, without further ado, inshallah, this simplifies the cerebrum and the blood supply of the brain. All right. So these are the four lectures that we'll be covering today. Cerebrum 1, Cerebrum 2, blood supply of the brain 1, and blood supply of the brain 2. I ordered them to be like in the most convenient or best way or best order inshallah. And inshallah the slides help you memorize this well. I think the slides would serve very, very amazingly as a second study or as a revision since they are pretty much really inclusive from transcriptions and from the slides themselves and from external resources. I even added some questions. So they are pretty inclusive, but I'd prefer or I'd encourage you guys to have a first study from the slides themselves, and then from here. And yeah, so we'll start first with the cerebrum 1 and 2. First of all, before we go into details, let's just start with the bigger picture. What is a cerebrum? So the human brain, it's a complex organ and it's made up of different parts. To simplify it better, it's just the way the scientist's way to explain it better. So it's made of cerebrum, cerebellum, and the brainstem. Cerebrum is the part that holds the highest functions, such as thought and like your personality, your actions, and so. Cerebellum, this is the part that has to do with coordination and balance. And brainstem, this is the part that has to do with automatic survival functions. All right, for today, we're not going to be focusing on the cerebellum and brainstem. We're going to be focusing about this cerebrum. And the whole brain is protected by three membrane layers called the meninges, the dura, the arachnoid, and the pia mater. We will be touching upon these at the very, very end of this lecture, inshallah. So keep them in mind. And the brain is split into two hemispheres connected by the corpus callosum. I've added here a diagram to better explain it. So here are the layers of the brain: the skull, the dura mater, the arachnoid, the pia mater, then the white and the gray matter, which I'll explain more in a bit. And here's the brain. It's divided into lobes. So the cerebrum is all of this. Then the cerebellum is down, and the brainstem is here. All right, just as depicted in this picture. And the cerebrum is even further more divided into lobes. So what are these lobes? The frontal lobe, the parietal lobe, the occipital lobe. There's also the temporal lobe that you can see here, and the limbic lobe. All right. This is the corpus callosum that holds the two hemispheres together. And then there is the thalamus, the hypothalamus, and all of these deep organs or structures of the brain that will not be the focus of today's PAL. However, I believe they will be covered in another PAL, inshallah. So yeah, it consists of an outer cerebral cortex, and which is the gray matter, and an inner white matter. So what is the difference between gray and white matter? Gray matter is basically made of neuronal cell bodies, dendrites, and glial cells. So it acts as the brain's processing center for the thought, the memory, and voluntary actions. This is the gray matter. It is darker than the matter inside, which is the white matter, and it forms the outer layer. All right, the white matter, it's the myelinated axons, which serves as the network cables that transmits the signals between the different gray matter areas. For example, there's you guys can see there's a gray matter here, and then there's a gray matter inside. Right between them is the white matter, and it serves as a network or a cable between those two to transmit the signals and the action potentials, and so you get me. So the gray matter makes some structures such as the cerebral cortex, the basal ganglia, and inner like the inner basal ganglia, like here and here. All right, and the white matter makes up the corpus callosum, which I told you guys makes the junction between the two hemispheres, and the internal capsule, which we'll be talking about more later on, and the corona radiata. All right. This is a coronal section to better visualize what gray matter is and what white matter is. Um, in order for the brain to have an increased surface area, because if you were to spread it apart, it would take more surface area. So in order to increase it, um, there is gyri and sulci. Gyri and sulci are ridges and grooves of the brain. All right. So each groove is called a sulcus, plural is sulci, and each ridge is called gyrus, plural is gyri. All right. This is generally just to increase the surface area and to organize the function of the brain. Um, if for a shallow groove, it's just called a sulci, but for a deeper groove, it's called a fissure. All right. So this also helps organize the brain into different anatomical like parts, such as the main sulci and gyri that are used to better identify different parts or lobes of the brain. So the main ones that we know and that we commonly use are first the central sulcus or the fissure of Ronaldo. For some reason, I don't know why it's called like that, but basically, it separates the frontal and the parietal lobes. So I just showed you guys the different lobes. The frontal is up here, the parietal is up here, the occipital is posterior, and the temporal is over here, right? Um, what separates the frontal and the parietal is a fissure over here called fissure of Ronaldo, and this is the central sulcus. All right, you can see it depicted here. All right, it's this whole fissure. The lateral sulcus, or the Sylvian fissure, separates the temporal lobe from the frontal or the parietal lobe. All right, um, it's depicted here. So posterior ramus of lateral sulcus or sylvius, this is it. This whole fissure separates the temporal lobe over here from the parietal and the frontal over here. All right. Precentral sulcus is anterior to the precentral gyrus. All right. So here's the precentral gyrus, just anterior to the central sulcus, and interior to that is the precentral sulcus. All right. So as we said a bit before, gyri are the ridges and the grooves are the sulci. All right. And last, again, as we have a precentral sulcus, we also have a postcentral sulcus. Makes sense. So central has a pre before and a post after. So post central gyrus and then the post central sulcus. This is in the parietal lobe, right? The parieto-occipital sulcus, from its name, talks about parietal and occipital lobes. So it separates the parietal and occipital lobes. Makes sense for you to find it over here because the parietal is over here and the occipital is over here. So it would be here. All right. These are important terminologies and anatomical landmarks that you will have to memorize in order to make memorizing other structures easier. All right, and two other sulcuses that are important to know is the cingulate and the calcarine sulcus. The calcarine, I think I believe it's called like that, I'm not sure. It's located in the occipital lobe, and it's the site for the primary visual cortex. So where is that? It's over here. We'll also talk about it later. All right. It's genuinely all in the occipital lobe. It's not between any two lobes. It's just all in the occipital. All right. And the cingulate sulcus, it runs parallel to the corpus callosum. So if we said the corpus callosum is this purple structure over here, and runs parallel to it, that would be the cingulate sulcus in blue depicted over here. All right. And it is part of the limbic system. All right. Now, more about the five lobes that we discussed previously. The frontal, again, the parietal, temporal, occipital, and insular. So frontal is all, it's in the front from its name, all right? It's up front, and it's all about the higher level thinking, the personality, as I said, and movement. So when you have a certain like characteristic trait in your personality, you're angry, like let's say you're a very rational person or whatnot, this is all um controlled by your frontal lobe, all right? That's why it is the last lobe to develop fully. It's the frontal one because this is the lobe that helps in decision making, all right? The parietal lobe is the one right before, right posterior to the frontal lobe. It controls sensory processing and spatial awareness. When we talk about sensory, we mean the touch, the pain, um, and the somatosensory, يعني, processing that happens, and spatial awareness, such as being aware about like where your different body parts are. Is your hand up right now? Is your foot down? And so, all right. The temporal lobe is all about hearing, language, and memory. So, subhanallah, it's right. It's situated right um behind the ears. As you can see, it's on the sides. And this makes sense for it to be all about hearing, right? And why language and memory? Because what we hear, we need to interpret in language, and we also store as memory. So it also makes sense for it to be concerning the language and memory, all right? The occipital, right? Like most posteriorly, is all about vision and color motion recognition. From its name, occipital means it has to do with like vision or the eyes, right? Um, it's situated all the way in the back because of the vision or يعني yeah, the vision pathway. I'll talk about it later on. بس يعني it will stick inshallah later on. بس yeah. And lastly is a deep lobe. It's like deep situated lobe. It's called insular, and it's all about your emotions, your consciousness, and your taste. And it's also part of the limbic system. We'll not be talking much about the insular. We'll be talking more about the frontal, parietal, temporal, and occipital, inshallah. Now that we've discussed the basic knowledge and the foundation of all that we have to know, we'll start digging deep into the functional areas of the brain. So I hope you guys can all focus with me here right now. Inshallah, يعني it's easy for you to understand and to memorize. All right. So a way that scientists decided to like classify different areas for us to help us يعني memorize the different areas and their functions is by the Broadman areas categorization. So there is I think not sure around 50 areas or so of the Broadman, but of course we're not gonna memorize them all. But the ones that we memorize, you have to memorize by name and by number, because sometimes in the exam questions they reference it by name, and sometimes they refer to it by number. So please make sure you memorize them. You memorize both, and all right. So I'll be يعني explaining them more in a couple of slides, but this is just to show you how they're divided, and of course each area will have a different function, and in order to يعني what we need to memorize is not just the function or how it is normally, of course, we need to memorize what happens if it's damaged. So for each function or for each area, we'll be talking about its normal function and its um like syndrome that is related to it if it's damaged, or it's like symptoms and signs if it were to be damaged. So starting with the frontal lobe, we'll be taking each lobe by itself and talking about its broadband areas. So starting with the frontal lobe, we have the most important, the primary motor cortex broadband area 4. So it occupies the precentral gyrus, all right? We talked about the gyrus the um gyrus, I mean, from before. So gyrus over here, and this in red is the primary motor cortex. What is its function? It's to initiate voluntary movements, all right, by our skeletal muscles of the contralateral head and body. So this is something really important you guys have to keep in mind, that every part, like right now, if I'm talking about the primary motor cortex of the right side of my brain, then you have to always know and understand that it will be controlling what your left side. So it's all about the contralateral part. So the right side of your brain controls your left side of your body and head, and the left side of your brain controls your right side of your body and head. All right? So the electrical stimulation of these areas elicits movements of particular body parts. So if I want to move my hand in a certain way, the this area of my brain will be the one sending signals to my like deep structures of my brain, and then to my spinal cord, and then to my muscles in order to move it. All right, but um, something really important you guys need to know about this, like or related to this motor cortex area, is that it represents the somatotropic organization of the skeletal muscles, um, of the primary motor area, representing it in the motor homunculus. All right, so this is a very, very traumatic figure that we need to memorize in medicine, and I apologize for it, but it is really important. So this homunculus, which is Latin for little man. It shows how our body is, if or how our body would look like if it was depicted like literally by how our brain is. You get me? So do you see how like big the hands and like the face is regard like opposite to like the body? This is because it's showing how very high skilled and very complex and sophisticated the nerves regarding our hands and face is um in opposite to our the rest of our body. You get me? So this is how it's depicted. But one thing you need to know is, it is precise, but it is inverted and it's disproportionate. What does this mean? So if you guys can see here, um this is like a better figure to show. So basically, starting from the lateral, if we were to be concerned with the lateral part of this area, it will be in control of the abdomen, the pharynx, the tongue, like your GI, your meaning first your GI, and then moving up to your upper GI, and then your face, and then your upper limbs, and then your lower limb. All right. So as you go medial, or as you go more towards the midline, this will be concerning, or it will be controlling your lower limb. All right. So this is important to know, because later on we'll be talking about clinical significance or a correlation regarding this. So when any kind of trauma or bleeding or anything happens to the midline or the medial area, it will be affecting the lower limb, and then the lateral upper area will be affecting the upper limb, and so and so. All right. Um, the blue depicts the somatosensory cortex, so this is regarding the touch and the senses, and the pink, it's regarding the motor cortex. This is the motor part that we're talking or discussing right now in the primary motor cortex. All right. All right, so yeah, as I said, every function we need to know, we'll also talk about the dysfunction or the damage. So damage to this area will cause upper motor neuron lesion. This will cause, on the contralateral side, of course, this will cause spastic paralysis, hyperreflexia, which is exaggerated reflexes, clonus, which is shown in this picture. So this is a way to test for clonus. Um, the physician would flex the knee and the ankle like this, and they would hold it for a second. And the patient with a positive like clonus sign, with their feet would start like going back and forth. All right, so it will be like somewhat shaking. All right, so this is clonus and a positive Babinski sign. Babinski is a reflex, or like it's a plantar reflex, or it's a sign that is normally positive in children or in pediatrics, but it's abnormally positive in adults. Why? It's because of an upper motor neuron lesion. So for adults, it is normal that whenever you elicit the plantar reflex by like swinging, or like by um touching the sole of the foot by like a wand or so, it is normal for the feet to plantar flex, right? So it will the toes will be inverted inside, all right? But if it's positive, which is abnormal, it will dorsiflex. So the toes of the feet will move towards the patient, all right? Not towards the like the other side, you get me? This is it for the primary motor cortex area. But what is one like low cortex or Brodmann area that is that has most to do with the primary motor cortex area? It's the premotor cortex area. The premotor cortex area is what controls and coordinates the primary motor. How it basically receives orders from all the different parts of the brain and conveys it to the area 4, or the primary motor cortex area. It controls and coordinates the complex and the purposeful, skillful, sequential muscle movements that you most probably require to play sports. All right. So if you want to go skiing, um, of course, it's not very like normal. It's not like a normal walk or so. Of course, you would need like very conscious and very complex types of skills and muscle movements that you need. So, and coordination. So this is all elicited by the premotor cortex area. All right. Damage to this area will lead to apraxia, which is the inability to perform learned complex motor sequences despite intact muscle strength and comprehension. So the muscles would be normally fine, like anatomy-wise and structure-wise, and they work well. It's just that that part of the brain does not work properly to help the person execute their learned or their acquired motor commands that they had before. So let's say they used to know how to ride a bicycle, they used to know how to play tennis and different types of sports, but any damage to that part of the cortex will not allow them to have that skill anymore. So مثلا they wouldn't know how to use a screwdriver or a whistle or so. Another cortex area, the frontal lobe, is the supplementary motor cortex. It's located anterior to the primary motor cortex, and so it is between area 4 and area 6. Primary motor cortex is area 4, as we said, and premotor cortex is area 6. So between them is the supplementary motor cortex, and it replaces area 6 if area 6 is damaged. So this is Subhanallah, like a blessing from Allah. So any damage to this supplementary motor cortex area will cause loss of spontaneous speech if located on the dominant hemisphere, and signs of upper motor neuron lesion. So what does this mean? We'll be talking more in a bit regarding like dominant hemispheres and whatnot, but the speech areas do not exist in both hemispheres. They only exist in your dominant hemisphere. And how do we know, or how do we locate a dominant hemisphere? Because the dominant hemisphere is not the same for all people. It's located, or it's determined depending on the location of the Wernicke's area and the Broca's area. We'll be talking more about these later on. But if the Wernicke's and Broca's area existed, let's say in a patient's right hemisphere, that means this is their dominated or their dominant hemisphere. And if that's their dominant hemisphere, then they will be left-sided because their right one is the dominant one, and the right, we said, controls what? The left. So they will be left-handed, and yes, that's basically it. But we'll be talking more about this later on, inshallah. Yes, exactly. This is what I was talking about, the Broca's area. So what is Broca's area? It's the motor speech area. It's areas 44 and 45. It's inferior to the frontal gyrus. So the frontal gyrus is right here. So it's inferior to it, and it's um regarding the it is the motor component of and the comprehension component of the speech. All right. So it is what helps a person translate thoughts into words and translate what you hear and see. And it is what helps you form the words in order to communicate, all right? So any damage to that area will cause motor aphasia and or conscious speech distortion. All right. So the patient wouldn't know what they're talking about, or any they're conscious about this. We'll be talking more about this later, كمان, inshallah. But they will be conscious about how distorted their speech is, and they know that something is not any normal about how they're talking, but they can't help it and they can't control it, so they just blabber any kind any kind of words that do not even make sense. You get me? And they also do not comprehend fully what people are telling them. The last area of the frontal lobe is the frontal oculomotor area. Area 8, or also called the frontal eye field. All right, this area is responsible for voluntary, saccadic, conjugate, and horizontal gaze or eye movement to contralateral visual space. So it helps communicate with extraocular muscles indirectly via the perimedian pontine reticular formation for you to gaze or to move your eye voluntarily in specific rhythms or eye movements. You get me? And any damage for that area, of course, will cause the loss of that horizontal conjugate gaze, and it will fixate the eye towards the lesion. So if there is a lesion in the right side of the brain in that area, the gaze will be fixated towards that lesion, any in the right side. Yeah. The last area is actually this one, the prefrontal cortex. The prefrontal cortex, from its name, it's the prefront. It forms the remaining part of the lateral surface of the frontal lobe. So it's and I've added pictures of all the lobes here so that you guys can imagine and visualize the areas. This it's generally, I think, the majority of the frontal lobe, and its function is this is the part of the frontal lobe that develops last, because it's the area that helps in judgment, in planning, in mood behavior, and basically in organizing your emotions and your intellectuality and aspects of your behavior and so on so. And of course, any damage in that area will cause changes in your mood, in your behavior, personality. This is the area that gets damaged when a patient shows up with personality disorders and even neglects. A patient with a damage in this area will neglect appearance and demonstrate no appreciation for social norms. They will have poor judgment, poor concentration, apathetic, emergence of infantile suckling or grasp reflexes, because they will like descend back to their um early years of life. Because as I said, since it gets developed later on in life, a baby would not, يعني normally you would not um expect a baby to have this frontal to have this area developed much yet, and that's why they have this grasp reflex, that's why they have this suckling reflex. So it makes sense if a person, an adult person who grew out of that reflex and خلاص they had their frontal prefrontal cortex developed, but then it got damaged, for them to descend and like go back to how they were before. You get me? Now that we're done with the frontal lobe, we start with the parietal lobe. Now, as a rule of thumb, the frontal lobe, as we said, has more to do with motor, the motor any part of your brain and your actions, and the parietal lobe will have more to do with your sensation or somatosensory um, like part. So the first area or the first cortex is the primary somatosensory cortex. It's areas 1, 2, and 3. All right? It's located here in the postcentral gyrus. So as we said, here is the central and it's posterior to it. So postcentral gyrus between the central and the postcentral sulci. All right? Makes sense. And it receives and processes sensory information from the body. All right? So it's all about conscious proprioception and general sensation. What is conscious proprioception? It is again what I first talked about. It's you consciously knowing and being aware about where different parts of your body are. So is your head, even if you were to close your eyes right now, you would still know if your head is tilted the right or left, like up or down, if your hands are and fingers are in a specific place in يعني in your space around you. You get me? Um, and this is generally how, and this is the part that controls all of that. And general sensations such as general like pain, temperature, and crude touch. Crude touch as in like not this like fine touch. All right. Um, any damage to this area will cause hypothesia or anesthesia on the contralateral side of the body. All right. So again, every kind of damage that happens in a certain part of the brain will only show its effects and its signs and symptoms on the contralateral side. All right. This is a very, very, very easy way for you to get tricked in an exam. So please focus on it when they ask you, oh, this part of the brain is damaged. Where would you expect to see the signs and symptoms? It's always on the contralateral side. And they could also ask you this in the other way around. So a patient presented to the clinic with signs and symptoms on the right side, where would you expect a lesion to be or the damage to be? On the left side, all right? So as as we talked about the homunculus in the primary motor cortex area, um, regarding the motor part of the homunculus, the primary somatosensory cortex area is also depicted in the sensory homunculus. All right, it again it's precise, it's disproportionate, and it's inverse. Um, so again, this is like if any blood supply like bleeding or occlusion happens, it will affect, and medially it will affect the upper body. This is what I'm trying to say here. I don't think it's worded appropriately, but yeah. Medially it will affect the upper body, as we said here. I mean laterally, sorry. And if anything were to happen medially, it will affect the lower body and genitalia. All right. The second area or any broadband area in the parietal lobe is the somatosensory association area, or also called the parietal association area. Broadband areas 5 and 7. All right. These receive and interpret the sensory signals from the body to the primary somatosensory area. So just the same way that the same way that we talked about it in the frontal lobe, right? It again, integration of signals from various sensory systems enables perception of size, shape, texture, and identification of objects by contact. something that is medically labeled as stereognosis, all right? Um, so it's you being able to identify an object just by like touching it. I'm I'm sure you guys have seen that type of like challenge that يعني we see on social media and so it's where they place an object inside a box and so you're not able to see the object but they allow you to touch it and you have to guess it by touching the object or sensing it. So this is where stereognosis comes into play. You are able to identify an object just by touching it and feeling its shape and its size and its texture, all right, without having to see it. But any damage that happens to this area will cause a stereognosia, which is the inability to recognize the object by touching, and apraxia, which is inability to execute learned motor commands. All right. Third, like area, Brodmann area in the parietal lobe is the supramarginal area 40 and the angular gyri area 39, which is the major association cortex. All right. This is where it gets to do with the dominant versus the non-dominant hemisphere. But basically, let me show you. Yes, let me show you here. Let me show you the areas here first, and then we'll talk about more regarding the dominant and non-dominant. So basically, these are regions of the convergence of visual, auditory, and somatosensory info. They are critical for complex functions like language, reading, writing, and calculation when in the dominant hemisphere. All right. So their functions and their damage differs يعني according to where they are located in. If it's in the dominant hemisphere, then it has to do with complex functions like the language, reading, writing, and calculating. And if it was to be damaged in the dominant hemisphere, it will lead to something syndrome called the Gerstmann syndrome, which will appear or present as agraphia, which is inability to draw, I believe, alexia, inability to read, and finger agnosia, which is inability to identify your fingers, acalcula, which is inability to calculate, um, and right and left confusion. So you do not know your right from your left, all right? This is if it was to be in the dominant hemisphere. However, if these were to appear or to be located in the non-dominant hemisphere, their function shifts from language to spatial awareness. Subhanallah. So it will be involving your relationship to your surroundings and your sense of location. So your awareness of your different body parts, again, what we talked about previously regarding the um like consciousness. What was the name again? Yes, the proprioception, conscious proprioception, all right? So yeah, damage to this area will cause a very, very, very interesting syndrome. It's called hemi-neglect syndrome or contralateral neglect. So basically, if this area were to be damaged in a patient's يعني right hemisphere, it will affect their left. So they will neglect their left side completely, as in if they were to shave their beard, they will not shave the left side. They will only shave their right side, right? If they were to apply lipstick, they will only apply it on the right side. They won't apply it on the left. It's not that they are doing this on purpose. They're completely unconscious when it comes to um يعني doing all of these on one side. It's just that their brain does not identify or recognize that side anymore. It completely ignores it. So even if you were to ask them to eat from a plate, they will only eat from one half of the plate and completely ignore the other half. If they were to draw anything, for example, this drawing here, this is how a normal person would draw a cat, and this is how a person or a patient with Hemming neglect syndrome would draw a cat. They will only draw one half of it. This is also how they will draw a clock. And this is how they perceive it actually. So they only see one half of it. They will write everything on one half they completely ignore the other half. All right. There are types of neglect. It's not just motor neglect. There is conceptual sensory neglect, which is their brain ignoring sensations from the affected side. So they do not feel anything or any touch or any sensation on that side. And there is motor neglect, which is their brain ignoring everything from يعني or deciding not to move or not to function on that affected side, even though the muscles are intact, they they are يعني not damaged per se. It's just that part of the brain that does not send any electrical impulses to that muscle for it to move anymore. So that's why it does not move at all. And there is a type of neglect that is both mix of motor and sensory neglect. So back to the concept of dominance. All right, so basically it talks about the يعني again what I mentioned regarding the location of the language areas, which are Broca's and Wernicke's. We're gonna talk about Wernicke's later on, but we already discussed Broca's. So wherever they do not like these two areas do not show on both hemispheres. They only show in one, and wherever they show up in is the dominant hemisphere. All right. Um, the function of the brain areas like the supramarginal and the angular gyri depend on whether they are in dominant or non-dominant, again, as we said. And if they are in the left cortex, then the left cortex is the dominant. If they are on the right, then the right is the dominant. Again, they do not present on both sides, and in 96% of the people, the speech areas are located in the left hemisphere. Makes sense because it is way more common to have a person be right-handed than to have them be left-handed, right? We all know this because there is a correlation with that. So if يعني since most of us are right-handed, we our left hemisphere is the dominant one. All right. So 90% of people, if speech areas are in the left, or if they're left dominant, they will be right-handed. If on the right, the person will be left-handed. I believe, inshallah, by now you guys have grasped this idea or this concept. It is really interesting. بس يعني in the beginning it's a bit confusing, but I believe, inshallah, you guys got it. So these are the two areas that I was referring to, the angular gyri over here and the supramarginal gyri, or gyrus, I mean, over here. So again, whenever they ask you anything regarding these two areas, make sure, please, 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 to first focus on where are they located or where are they situated in that scenario. Are they in the dominant hemisphere or are they in the non-dominant? Because it differs functionally and damage-wise. All right? Now that we're done with the parietal lobe, we're gonna move on to the temporal lobe. Temporal lobe, first of all, we have the primary auditory cortex because I explained how auditory sensations are all in regards to the temporal lobe since it's situated right below the ear. All right, so it's close to the structure and it makes sense for it to be there. It is found on the floor of the lateral sulcus or sylvian fissure. Remember the sylvian fissure we talked about? It's this sulcus over here. Fissure again is a deep groove. All right, and you guys can see how like it separates it really well. All right, so this is the part of the superior temporal gyrus and also known as the transverse temporal gyrus of Heschel. All right, it's areas 41 and 42, and any damage to these areas will damage the auditory sensation. All right, so each auditory cortex receives input from both ears, so damage to one side does not cause complete deafness. This is actually another, subhanallah, blessing from Allah. And the auditory input from both ears are sent and received by both auditory cortex on both sides. So if one ear or one side of any one auditory cortex is damaged from one of the both sides, it will not cause complete deafness. It will only cause partial deafness because you're still getting inputs from the other ear, يعني from both ears to the other area. You get me? And not only that, it also helps with sound localization. What does that mean? You are able to locate the sound or the direction, the sound and the direction it comes from. So even if if you were to close your eyes, you would know where someone is clapping in a room. You get me? You would know where the keys fell, يعني at which direction, even like were they far, were they close by, and so. All right. The second area is the secondary auditory cortex, area 22, I'm sorry, or the auditory association area. It surrounds the primary auditory cortex, so it's around it, as you can see here. So we said 41, 42 is the primary auditory, and 22 is the secondary auditory. So makes sense, name-wise and location-wise, subhanallah. And function, it's the comprehension of the spoken language. So as we said, 41 and 42 is I told you guys parietal lobe also has to, I mean temporal lobe, I'm sorry, has to do with not only like auditory sensations and hearing. No, it also has to do with comprehending. Why? Because after you have heard يعني all the sounds and all the language, you need to interpret it. You need to comprehend it. So comprehending the spoken language that you heard and interpreting it, other sounds like such as musical tunes and bird songs and whatnot, is all in this area, the secondary auditory cortex. All right. The third area is the primary olfactory cortex, area 34. Um, يعني other areas that are also related to this يعني function is also the entorhinal cortex, area 28, and uncus. All right, these all like this group of broadband areas are related to the smell, the olfaction. All right, subhanallah, they are situated يعني most inferiorly in the temporal lobe, which makes sense for them to be close to the nose, right? And they are located on the parahippocampal gyrus, which also contains the hippocampus. And this is also important because hippocampus has to do with memory, right? So whenever, يعني subhanAllah, this is also part of the olfaction pathway. Whenever your olfactory bulb and olfactory tract receive any like smells or like chemicals regarding smell um and olfaction, it goes to your hippocampus and your memory to identify if you have smelled that before, or is that a bad smell, is that a good smell, do you have to stay away, no it's okay, you love it, no you don't, you get me, this is important even when it comes to survival and so. And again, these areas all will receive the olfactory fibers from the olfactory bulb and olfactory tract. So it goes first to the thalamus before reaching that part of the cortex. So before reaching the primary olfactory cortex and so to like uh يعني have to do or to order like the smell and so. And as a rule of thumb, again, all sensations. All right, I think I messed up in this point. So what I want, what is, I messed up when it comes to the thalamus and so. Um, the correct fact, however, is that all sensations or sensory pathways will relay in the thalamus before reaching the cerebral cortex, except the smell and olfaction. My bad, guys. I'm sorry. I forgot about this exception. So basically, what I meant was like the visual, the sensory, the hearing, and I wanted to discuss the hearing, but I jumped to the smell or the olfaction. So all other kinds of sensations, or like our five senses, first relay in the thalamus or the hippocampus for us to store memories regarding it, and for future reference and so for survival, except for the smell olfaction, it goes quickly or directly to the olfactory cortex. I believe انه there it still it still goes to the thalamus later on, or to it still gets stored as memory بس does not go first to that area. I'm not very sure regarding this, but this is what I remember الصراحة. But please do double check before you memorize this part. Another area of the Boardman area of the temporal lobe is a very, very important one. It's the Wernicke's area. This was the area that I was discussing previously alongside the Broca's area because they do go hand in hand. It is Boardman area 22, or it's the posterior section of Boardman area 22, and it's part of the 39 and 40. All right, it's actually the meeting point of the temporal over here, the parietal over here, and the occipital lobe over here. Subhanallah. And it is a sensory integration zone. So it interprets varied sensations and varied sensory informations to perceive and recognize the meaning. Um, like whether of the sentences that are heard, like that are read, that are written, or even the thoughts that are developed in your brain, it is all about comprehending that, and يعني it goes hand in hand with Broca's because Broca is forming the speech and Wernicke is comprehending it, all right? So basically, a better way to explain it is telling you guys that speech is defined as the translation of your thoughts into words, right? And it involves two main components. So the comprehension component and the motor component. The motor component is translating your thoughts into spoken words. يعني obviously. And so the motor component of speech is located in Broca's area. This is what I was telling you guys. And any damage there will result in inability to produce words. So motor aphasia. So the patient is aware of the deficit. This is really important because in Wernicke's, they're not aware. So the patient is aware that they're not able to produce words how they used to before. You get me? Um, and the other part of, or the other component of the speech is the comprehension part. This is like controlled by the Wernicke's area, and any damage there results in inability to comprehend the speech. So unconsciously, the patient would not be able to translate their thoughts into words, or the words that they've heard or perceived, they're not able to comprehend them well, and they can't understand what they read or what they write, and they can't produce words that are sensical. Yani they produce words because they do not have a problem with production of the words. They can't produce it. But it does not make sense because yani of course obviously if they cannot comprehend what they've heard and they cannot comprehend their thoughts and yani their thought process, and so they're not able to comprehend or to produce sensical words. You get me? And the main difference that I want you guys to keep in mind here is that Broca's is they're aware, but Wernicke's they're not aware of their deficit. Um, Additional notes on localization that is that the spoken language and the comprehension is a primary function of area 22. Again, this is just like a reminder. Broca's area and written is 39, Wernicke's area. Damage to these can cause conduction aphasia, which is يعني both damage to both areas. So the comprehension area, Wernicke's, and the production area, Broca's, they communicate together, right? Of course they do. يعني this makes sense. They communicate together in order to form and to comprehend and to form speech. They are connected by a bundle of fibers called the arcuate fasciculus. Fasciculus, I don't know. Yes, fasciculus. Also known as the superior longitudinal fasciculus. All right. Um, any lesion, however, or damage affecting this bundle of fibers, such as stroke or tumor, will result in conduction aphasia. This is like a syndrome called disconnect syndrome. So the patient is aware of them not being able to count backwards, or not being able to name objects, or not being able to repeat words. And after the physician, I'm sorry. بس they're not يعني the production remains normal, so they can produce normal speech, but they're not able to comprehend normally. You get me? I'm sorry, this is when it comes to Wernicke's. It does not have to do with Broca's, all right? So Broca's is intact, but Wernicke's is not. Now that we're done with the temporal, we're gonna move to the occipital lobe. This is the last lobe when it comes to Brodmann areas. So, Brodmann area 17, or the primary visual cortex, is the main area when it comes to occipital lobe. It is located most posteriorly in the medial surface along the margins of the calcarine sulcus. All right, it's also known as the striae area. So, as you guys can see here, its function is to receive visual information. يعني يعني self-explanatory by the name بس إنه to receive visual information from the contralateral visual field via the optic radiation. Um, in order to understand this better, it is really important to understand the whole visual pathway. So I've included this here alongside a picture. Inshallah, you guys will be able to understand it quickly. So and easily. So basically, when we look at anything, we have photoreceptors in our retina, okay? Like the rods and cones, they interpret the light of our image, all right? And at anything we look at, there is from each eye lobe or from each from each eye, there is a right and a left. So let's say right now I'm closing my left eye and I'm looking just from my right eye. It's divided in half and there is a right and there is a left. Same thing with the left eye. There is a right and a left. All right. So, subhanallah, in both areas, and if divided in half, both rights are depicted by the left cortex, and both lefts are depicted or are translated or go or relay to the right area. So again, it's all about them being contralateral. All right. So basically, the pathway is first start with the visual field. For the sake of this example, we're going to use the right visual field. All right. So the right visual field of both eyes. All right. So let's say you're looking خلاص normally in front of you, but again, from every eye, the image is cut in half. There's a right and there's left. All right. So the right visual fields of both eye um are relayed. The photo receptors relay the image or the electrical impulse to the left retina. All right, as you guys can see here. So right and right are relayed to the left retina. Okay, here. All right. And from there it goes to the optic nerve, as you guys can see here. All right. So we're discussing right now the red color. All right. So optic nerve. From the optic nerve or the cranial nerve 2, it goes to the optic chiasm, as you guys can see over here. All right. From there it goes to the optic tract. All right. And to the lateral geniculate body or the thalamus, because as I said, it's shown here. All right. The thalamus is this in the middle. As I said, all sensations are relayed in the thalamus before they reach their respective cortex area, except the olfaction or the smell. All right. So from the thalamus, and after it gets relayed in the thalamus, it goes and completes its way to its respective cortex area through the optic radiation. All right. And then to the left primary visual cortex. So because it was the right visual field, it goes to the left visual cortex. If it was the left visual field, it goes to the right visual cortex. Please do not make this confuse you. Inshallah, it's easy. And the same principle applies in reverse again. Left visual field information goes to the right. All right. If any damage were to happen to that area, it will cause loss of the contralateral visual field. Makes sense. So let's say there is back to the picture, there is a problem in the right visual cortex area. So here, all right, there's a problem in this cortex area. They won't be able to see the left visual fields. So just how it's depicted in this picture. So they will have something called left homonymous hemionopia, all right, which is loss of the contralateral visual field. It could be a tumor compressing, like مثلا the optic chiasm or something. It could be, compressing the cortex area or trauma to that area. And by definition, homonymous, homonymous means on the same side for both eyes, and hymenopia means loss of half of the visual field, all right? Because there are different types of visual loss. One type is this contralateral homonymous hymenopia. Okay, so patient um with that would this is how they would see, or this is how they would visualize in front of them, right? Um An exception, however, if there was injury to the visual cortex caused by an occlusion, يعني especially or specifically an occlusion to the posterior cerebral artery, exclusively it will result in homonymous hymenopia with macular sparing. What does this mean? Macula is like the center, all right? And if it's spared, that means they are still able to visualize the center, all right? So we went from this no macular sparing to this macular sparing, because the area that receives the macular visual field, subhanallah, has dual blood supply, all right? So from middle cerebral artery and from the posterior cerebral artery. We'll be talking more about this in the blood supply section of this PAL, inshallah. But this is important to note for if a exam question comes any noting that there is macular sparing, you should know that it has to do with the posterior cerebral artery, right? The second Brodmann area in the occipital lobe is the secondary visual cortex, or area 18 or 19, or it's also called visual association area. It forms the rest of the occipital lobe, as you guys can see here. This dark red is the primary visual cortex, and this light red or orange is the secondary visual cortex. It forms the rest of the occipital lobe, and it's also called extrastriate area. All right. Its function is to interpret the visual for information that was received by the primary visual cortex, and interpret its color, its shape, and its movement. All right. So you are able to interpret like the ball that is in front of you. You would be able to see its color, its shape, and how it's moving, all right? And you relate the current visual input to past visual experiences to enable recognition. This is all in regards to memory. Any damage that happens here will result in visual agnosia, which is where the patient can see the object, but they cannot describe it because they cannot comprehend its shape, its size. I'm sorry, they can describe it, but they cannot recognize or identify what it is. So they can tell you, for example, that the keys are gray and they are like sharp, they are like circular at the top and whatnot, but they cannot tell you these are keys. They cannot identify an object, they can just describe it. All right. Um I believe we're done with the Broadman areas, but before we finish these two lectures of the cerebrum, I have to this is something that was mentioned in your lecture, so I included it for the sake of um يعني completing the lecture. Um, it's the body part representation. So again, I think this was mentioned in the homunculus, which is the medial surface of the lobe represents the lower limb region. So any damage that happens to the medial surface of the cortex will affect the lower limb region. And it's also supplied by the anterior cerebral artery. We'll talk more about this in the next part. Um, Opposite to that, the lateral surface area of the cortex represents the upper limb, the face, the trunk, and is supplied by the middle cerebral artery. What is the clinical significance here is that any ischemia or damage happening to, for example, the anterior cerebral artery will cause paralysis or loss of sensation in the contralateral lower limb. And this helps differentiate between anterior cerebral artery stroke, which affects the lower limb, and middle cerebral artery stroke, which affects the face and the upper limb part. Um, this is a very easy way to recognize the area that is damaged or the artery that is suffering from a stroke or occluded or so in an exam question, just by knowing which area affects which. All right. So as we end, or as we conclude the first two lectures, cerebrum lectures, I have a couple of questions here. But before I read them again, please do not hesitate to send me or email me any questions that you have regarding those. Since this is a recorded session, I cannot يعني, have you ask the questions right now, but please do not hesitate to send them my way. Inshallah, I'll be able to help. So here's the first question. Please do pause the video after each question and try to answer it on your own before I show you or reveal the answer. So first, a 68-year-old man suffers a stroke affecting the precentral gyrus. On physical examination, which of the following findings would be expected on the contralateral side of his body? Flaccid paralysis, absent reflexes, muscle atrophy, spastic paralysis, hyperreflexia, and and an upgoing plantar reflex or Babinski sign, positive Babinski sign, loss of all sensory modalities, inability to perform learned motor sequences despite normal strength, or complete anesthesia. We did mention this before. So it is spastic paralysis, hyperreflexia, and an upgoing plantar reflex or Babinski sign. I hope it makes sense because it's genuinely pure recall. The second question is a 62-year-old woman is brought to the clinic by her daughter, who reports that her mother has been speaking in a way that doesn't make sense. When asked, how is she feeling? The patient responds, "Oh, the clouds are happy today, and the hospital is running with purple ideas." She appears unaware that anything is wrong. Where is the lesion? This is how I told you guys, like, a, one way they would write a question. They would tell you what is the damage and they ask you for the location, or any the opposite. So A, left inferior frontal gyrus, B, left superior temporal gyrus, C, right parietal lobe, D, precentral gyrus, and E, cassarine sulcus. The answer is B, left superior temporal gyrus. I hope you guys remember when we discussed it. No, they do not. They are speaking normally, but they are unconscious about how they do not make sense. You get me? And now that we're done with the first half of the PAL, we're gonna start the second half, the blood supply of the brain, lectures 1 and 2. Some key facts to know before we dig deep into all the details, is that first of all, unfortunately, cerebrovascular diseases are among the top 5 leading causes of death. Why? It's because the brain is a very sensitive organ, and any lack of blood and oxygen for even like minimum time, just a couple of seconds, would affect the brain. And there is a threshold for that. So if normally the brain receives about 800 milliliter of blood per minute, which is about 20% of the cardiac output. However, if the blood flow drops below 15 milliliter per 100 grams of brain tissue, there will be irreversible ischemia that will occur. And this ischemia will lead to tissue damage in the brain. And the bad news is that unlike skin cells that can regenerate constantly even after any type of ischemia or tissue damage, the neurons or the brain cells do not regenerate. Why? It's because neurons are post-mitotic. They're in the post-mitotic phase, so they do not divide or replace themselves after any damage, and therefore, when a neuron is lost, it is permanently lost and cannot be regenerated. That's why the brain is a highly sensitive organ, and it is there are so many um, like strategies or um, like I don't know what it's called, any different um, modalities that are like used in the hospital settings to make sure that the brain does not like go through severe blood or oxygen loss. You get me? I hope it makes sense. But yeah, um, mainly talking, starting from the big picture again, just how we did in the cerebrum, the blood supply to the brain comes from four main arteries. What are they? The two internal carotid arteries and two vertebral arteries. The vertebral arteries, they arise from where? If we start from the heart and from the arch of aorta or the aortic arch, from there we have different arteries that come, right? One of them is the subclavian artery. The subclavian artery will divide into vertebral arteries, and the vertebral arteries will enter the base of the skull, يعني will run through or parallel to the vertebra, the cervical vertebra, and will enter the skull through the foramen magnum. Alright? The internal carotid artery will enter the base of the skull through the carotid canal and emerge through the foramen lacerum. These are like quick points that you need to memorize. Yani they might be minutiae, but they're good to know in case they were asked in like an MCQ. You know where like each artery emerges from or enters the skull from. All right. In the brain there are two circulations. There's an anterior circulation, which is supplying the anterior part of the brain, and the posterior circulation, which is supplying the posterior part of the brain. So, and the anterior one is supplied by the bilateral internal carotid arteries, and they supply the frontal lobe, the parietal lobe, and the majority of the temporal lobe. The posterior circulation is supplied by bilateral vertebral arteries joining to form a singular basilar artery, and they supply the rest of the temporal lobe, the occipital lobe, and the rest of the brain. All right, such as like the cerebellum, and the midbrain, and the brainstem and so. All right. First of all, let's discuss the internal carotid arteries. So again, as we said earlier, that subclavian artery give rise to the common carotid artery. From there, it divides or bifurcates to give two branches: the external carotid artery right here, which is يعني externally, and the internal carotid artery. Now, where does this bifurcation happens? It happens at the level of the thyroid cartilage, or the upper يعني border of the thyroid cartilage. And subhanAllah, this is where you أصلا feel for the carotid pulse. So you press against like medially against the upper border of the thyroid cartilage to assess for the carotid pulse. There is also two important structures. First of all, the carotid sinus, which is the baroreceptor that senses any change in blood pressure. And there's also the carotid body, which is a chemoreceptor that senses changes in the chemical constituents of the blood and is particularly sensitive to the carbon dioxide. All right. This is an image to depict what we're talking about. Another important structure is the cavernous sinus. As you guys can see here, it is a venous structure that is present on both sides of the sella turcica, which contains the pituitary gland. All right, it's a gland situated deeply inside of يعني between the brain structures, and inside this cavernous sinus, you will find cranial nerves running alongside the internal carotid artery. So there are cranial nerves 3, 4, and 6, which are responsible for the eye movements, and cranial nerve 5-1, which is ophthalmic, and cranial nerve 5-2, which is maxillary. There's also the mandibular division that does not pass through the cavernous sinus. All right, these are just mentioned in your lecture, so I had to make sure I should mention them just for completeness sake. How does the internal carotid artery course or move in the brain? It passes through the cavernous sinus, as I said, near the pituitary gland, and penetrates through the foramen lacerum. All right. It then penetrates the arachnoid membrane and enters the subarachnoid space and continues branching from there. This is where it starts forming the circle of Rees. So there will be different branches from the internal carotid artery from there. So as you guys can see, this is the internal carotid artery opening, and it gives a direct branch that is the middle cerebral artery, we'll be discussing each of them later on in a bit. And there is an anterior branch that goes anteriorly, yani to the anterior side of the brain, because this is the frontal lobe, so it's anterior. It's the anterior cerebral artery from its name. So middle cerebral artery and the anterior cerebral artery. You would think that the posterior branch would be called posterior cerebral artery, but that's not true. The posterior branch is the posterior communicating artery, because posterior cerebral artery is part of the basilar artery. All right, so please do not confuse yourself. Let's first discuss the middle cerebral artery. The middle cerebral artery is, as we said previously, a direct continuation of the internal carotid artery, right? Therefore, this is very important clinically. Why? Because any emboli or thrombi or ischemia that happens or affects the internal carotid artery will often, most commonly, travel directly to the where? To the middle cerebral artery. Makes sense. And this is why the middle cerebral artery is the most commonly affected artery in strokes or cerebrovascular accidents. It enters, however, now that we've discussed that, its path or course of direction or action is in it enters the lateral sulcus of the sylvius, all right, also called the lateral fissure, which this is the lateral sulcus of sylvius, all right, to reach the lateral surface of the brain and supply the frontal, parietal, and most of the temporal lobe, um, as I said previously. This is an image to show you guys what, like, which artery supplies what area. So right now we're discussing the middle cerebral artery, and subhanAllah, as you guys can see, it's generally supplies the majority of the brain. As you guys can see here, the anterior is up here and the posterior is down there, all right? The middle cerebral artery gives off more arteries. Firstly, it gives off lateral lenticular striate arteries that supply the basal ganglia and the genu and posterior limb of the internal capsule. All right. Any ischemia that happens there will cause what? Complete contralateral hemiparesis and contralateral hemianesthesia. All right. Um, because all the descending motor fibers and ascending sensory fibers are where they're concentrated in that tiny area of the internal capsule that will get affected. And around that internal capsule, it's surrounded by the caudate nucleus, the thalamus, the putamen, and the globus pallidus. So as you guys can see here, number 3 is the lateral lenticular striate arteries. So these that are given off by the middle cerebral artery, and as they go medially, they supply the internal capsule and the thalamus and all of that. And since these are the areas that will hold um, the motor fibers and the sensory fibers, any damage that happens there will affect any the motor function, so it will cause hemiparesis, so contralaterally, which is inability to move, and hemianesthesia when it comes to sensory, so they will lose sensation. All right. When it comes to internal capsule is an important structure that I believe will be discussed further on in the next pal. But it's basically to touch upon it, yani, since we are mentioning it. It's a V-shaped white matter structure, as I said before, formed by an anterior limb. So this is an anterior limb, anteriorly, a posterior limb, and it's connected by the genu that I mentioned. All right. It's made of fiber tracts. So it has the genu has the corticobulbar tract. The posterior limb has the corticospinal tract or the corticopontine fibers, the corticothalamic fibers, and the ascending limb will have the thalamocortical radiations that carry all sensations from the thalamus to the cortex. All right. The blood supply to this internal capsule is anteriorly, and for the anterior limb, it's supplied by the anterior cerebral artery, which we'll be discussing in a bit. But the one that we are concerned with right now is the posterior limb at the gnu, which is supplied by the middle cerebral artery, by the lateral lenticular striate arteries that I just mentioned were branches of the middle cerebral artery. And something that is very important, or the clinical significance that happens here is lacunar infarcts. What are these? Lacunar infarcts are very minimal, very small infarctions that happen in small arteries such as the lenticular ray arteries. So basically it's loss of blood supply to the posterior limb of the anterior internal capsule. Why? Because it is the part that is um supplied by the lenticular striate, and it's usually due to any occlusion that happens there. And it causes complete contralateral paralysis and sensory loss, while the middle cerebral artery occlusion mainly affects the face, hand, and upper limb. Right? So it's important to differentiate. All right. So this is an important any fact to appreciate is that if any complete contralateral paralysis and sensory loss happens just from the occlusion of lenticular striate artery. What do you think will be the signs and symptoms of occlusion of the middle cerebral artery? So there's unfortunately so many signs and symptoms that will occur. Firstly, paralysis. So contralateral face and upper limb paralysis if the posterior limb is involved. Loss of sensation contralaterally in the face and upper limb. Aphasia if dominant hemisphere is affected, such as Broca's or Wernicke's. Gerstmann syndrome if areas 39 and 40 are affected in dominant hemisphere. Contralateral neglect, which is what we covered previously, if non-dominant hemisphere is affected. Apraxia, eye movement deficits, and higher cortical dysfunction, depending on the affected cortical areas. And lastly, internal capsule lacunar infarcts that we just mentioned. So, subhanAllah, this just shows you how big of an impact or in devastating effect a small artery would have. Now that we're done with the middle cerebral artery, we're going to discuss the anterior cerebral artery. So it travels towards the longitudinal fissure and the arches over the corpus callosum that we talked about in the middle, to supply the medial surface of the brain. It also supplies the upper inch of the frontal and parietal lobes, just how it was shown in the previous picture, that was not covered by the middle cerebral artery, and it also supplies the olfactory bulb and tract. All right. This is the anterior cerebral artery over here, and this is the middle cerebral artery that we talked about, as you guys can see. Any occlusion that happens here will cause hemiparesis, or hemiplegia, which is contralateral, mostly lower limb and pelvic floor, loss of motor abilities and loss of sensations. It will also cause apraxia, which is premotor area medially, in the premotor area medially, I mean. Due to that area, I'm sorry. Contralateral sensory loss in the lower limb and perineum. A somatosensory association can be also affected. Urinary incontinence, sometimes fecal too, because of the damage to the medial pericentral lobule. Lastly, anosmia, which is loss of smell or olfaction due to it being supplied by this artery. So this is to show you, this is a sagittal cross section to show you from laterally what area is supplied by the anterior cerebral artery. All right. Another artery is the posterior communicating artery. All right. This is the third artery the third major artery that we talked about that branches off the internal carotid artery. As you guys can see, it's over here. So posterior communicating, middle cerebral, and anterior communicating, or anterior cerebral. All right. Posterior communicating is the third major branch, as we said, and two arteries that communicate between the anterior circulation. There are two arteries. They are the ones that communicate between the anterior circulation and the posterior circulation. All right. As depicted in this image. Another artery that I just talked about, which is right here, it's the anterior communicating artery. From its name, it communicates the anterior arteries. So it's a single artery that connects the right and left anterior circulation and is located in close proximity to the pituitary gland. On top of the pituitary gland is the optic chiasm. This is important to know because any kind of aneurysm that happens there in the anterior communicating artery will affect the optic chiasm and it will cause bitemporal hemanopia. Sometimes, if it ruptures, it causes hematoma and bleeding, which puts pressure on the corpus callosum. And if there is any loss of blood supply to the anterior communicating artery, there is less blood to the frontal lobe. And this will cause higher mental function problems or psychopathological problems, just like how I explained in the beginning of the lecture. Um, Other minor arteries that are any found in the brain, any that are not any one of the three major, are the ophthalmic artery. Firstly, it's a branch of the internal carotid artery and it travels to the eye and supplies blood to all the structures within the orbit, as you guys can see, the nose, part of the scalp, and the paranasal sinuses. The second minor artery is the central retinal artery. It is a branch of the ophthalmic artery that we just mentioned, and it travels inside the substance of this optic nerve. It is crucial. Its crucial role is that it supplies the blood to the retina. This is so important. All right? Why? Because any kind of ischemia that happens to this artery will cause, or thrombosis, will cause temporary blindness, also called amaurosis fugax or fugax, I'm not sure. This is just a warning sign of transient ischemic attack, but any kind of complete occlusion will cause permanent blindness. All right? The third minor artery is the anterior choroidal artery. It is a branch of the internal carotid artery that sometimes comes from the middle cerebral artery, and that travels to the choroid plexus of the lateral and third ventricle. It supplies important structures such as the thalamus, the basal ganglia, and the internal capsule. And any occlusion can cause the classic triad of hemiplegia, hemianesthesia, and sometimes hemanopia. All right? So it affect the motor, the sensory, and the um like the visual function sensations. All right? Um, Let me see if I can point it at it for you guys here. Uh, mm, Yes, it is here. Anterior choroidal artery. It's a branch, as you guys can see, from the internal carotid, okay? So it's a minor branch. The fourth one is the hypophyseal arteries. What are these? These are the ones, hypophysia means pituitary, all right? And so from its name, these are the arteries that support or supply the pituitary gland. They arise from the cavernous segment of the internal carotid artery, and they transport and support, and they support the pituitary gland and transport secretions from the hypothalamus to the pituitary through what? Through the superior and the inferior hypophyseal arteries, as you can see here. So here's the inferior hypophyseal artery, and here's the superior, all right? This is the pituitary gland that is in the sella turcica. The fifth artery is the vertebral artery. The vertebral arteries arise from the subclavian, as we mentioned before, and they ascend through the foramen magnum. All right, foramen magnum over here. All right. Um, then they unite to form the basilar artery, as you guys can see. The right and the left vertebral arteries unite to form basilar artery at the medulla pons junction. Right? It would be over here. The branches before union are it branches before the union, as you guys can see, and different branches coming. And what does it give off? It gives off the anterior spinal artery, the posterior spinal artery, the posterior the pica and I'll talk about it later, and the anterior spinal artery. Um, I'm sorry, the anterior spinal artery supplies the anterior two-thirds of the spinal cord. The posterior spinal artery supplies the posterior one-third of the spinal cord, and the posterior or the pica supplies the lateral medulla. Clinical note is that the anterior spinal artery occlusion causes medial medullary syndrome. What is that? It is and it shows it's the occlusion to that artery, and it shows contralateral paralysis or hemiparesis due to cortex spinal tract involvement, and ipsilateral tongue weakness due to hypoglossal nerve involvement, and lastly, loss of vibration, sense, and proprioception contralaterally due to medial lemniscus movement, or I'm sorry, involvement. All right. Another syndrome that is really important to know is the lateral medullary syndrome or the Wellenberg syndrome. It is caused by injury or occlusion of the pica, which is the posterior inferior cerebellar artery. And signs and symptoms of it would be ipsilateral loss or of vibration, sense, and proprioception, affecting the face, contralateral loss of and also contralateral loss of pain, and temperature sensation due to spinothalamic tract involvement affecting the body, right? It's shown here in this figure, the posterior inferior cerebellar arteries. So they're posterior and they are inferior to the cerebellum, all right? Um, Lastly, I believe is the basilar artery. So this is the how what we talked about the junction of the two vertebral arteries that unite at the medullary angle. It branches to give the anterior inferior cerebellar artery, the superior cerebellar artery, and the posterior cerebral artery. So please do not confuse between cerebral and cerebellar. One is for the cerebrum, the other is for the cerebellum. And again, the posterior communicating artery is from the internal carotid, but the posterior cerebral artery is from the basilar, all right? And it also gives the pontine arteries shown here, which are supplying the pons, all right? Any occlusion that happens to these arteries cause what? Lateral pontine syndrome. Its signs and symptoms are facial droop, so it affects the facial nucleus and facial nerve, causing ipsilateral paralysis of upper and lower face, ipsilateral loss of lacrimation, tear production, and salvation, and loss of taste on interior two-thirds of the tongue, loss of corneal reflex, and vertigo, contralateral loss of pain and temperature, the Horner syndrome, which is ptosis, meiosis, and anhidrosis. This is any majorly a purely memorization. That's why I'm skimming through quickly. And another artery, I'm sorry, that was not the last, is the posterior cerebral artery. This is the one that I was just telling you guys about. It's posterior to the superior cerebellar artery, and it curves around the midbrain and cerebral peduncles to reach the occipital cortex and supplies the occipital lobe, the lower part of the temporal lobe, and the deep brain structures such as the midbrain and the thalamus. It is important to note that the cranial nerve 3 runs between the posterior cerebral artery and the superior cerebellar artery. Um, just as depicted here, as you guys can see, the posterior one and the superior cerebellar one. Just between them runs what? The cranial nerve 3. All right? So any occlusion that happens to these to the posterior cerebellar artery would cause what? Occipital lobe, hymenopia with macular sparing. As we said, for the thalamus, it will cause contralateral hemianesthesia. Um, hemianesthesia. For the midbrain and brainstem, it will cause deficits. Deficits corresponding to midbrain and brainstem involvement. For the inferior medial temporal lobe, it causes memory defects. For the it also causes prosopagnosia, which is inability to recognize faces due to the damage of the fusiform gyrus, and alexia and agraphia, which is inability to read or draw, and visual agnosia, which is inability to recognize objects. Talked about this. Now that we've identified all and labeled all the arteries and what happens if they were to be damaged, let's talk about the diagram that we've been looking at for the past couple of slides, which is the circle of Willis. This is an important diagram that you need to memorize by heart. It's the connection between the anterior circulation and which is the internal carotid artery branches, and the posterior circulation, which is the vertebrobasilar system. All right. The internal carotid arteries give rise to the anterior cerebral arteries connected by the anterior communicating artery, as we said. And this is the most common site for what, as depicted here, barrier aneurysms. So this place here, it's the most common site for barrier aneurysms. Please memorize this. The posterior cerebral arteries connect the internal carotids via the posterior communicating arteries. And this whole circle, what does it include? It includes the anterior cerebellar artery, the anterior communicating artery, the internal carotids, the posterior communicating artery, and the posterior cerebellar artery. Why is this important? It helps maintain brain perfusion if one major artery is blocked. All right. Now that we've done with this, let's quickly mention the meninges blood supply. So the dural blood supply comes mainly from the external carotid artery and also from the internal carotid and vertebral arteries. A key branch or a key artery is the middle meningeal artery because it comes from the maxillary artery and enters the skull via the foramen spinosum and leaves grooves on the inner skull of the surface, but it supplies the majority of the meninge. Other contributors are the superficial temporal, the accessory middle meningeal, and the ascending pharyngeal artery and occipital artery. Um, a vulnerable area is the pterion, arterion. Sorry. It is a common site for access or injury because it's located laterally in the skull and its thickness it's a very thin plate of bone and it's an area where the four skull bones meet. An impact for this area can rupture the middle meningeal artery underneath and cause epidural hematoma. What is epidural hematoma? It is on imaging, it shows lemon-shaped or biconvex lentiform shape on X-ray or CT scan, and it's accumulation of blood that compresses the brain, so it's very dangerous. Clinically, in a clinical course, initially, the patient will not have symptoms, so that's why it's described as lucid interval. But then gradually, the patient deteriorates and loses consciousness. The management is surgical evacuation, which is very important to evacuate the blood. Another type of hematoma is subdural hematoma. It involves veins, not the arteries, and it's usually basically always the trauma of the rupturing, bridging veins. So the blood is forced by arterial pressure between the dura and arachnoid or split dura. So it's below the dura, it's subdural. On imaging, it will show banana-shaped, crescent-shaped, blood accumulation that's concave on the outside and follows the contour of the brain, as you guys can see. Clinically, we have acute and chronic types. Acute, it's sudden severe bleeding. It's an emergency. Chronic, it's slow, gradual accumulation of blood over time. The last hematoma type is subarachnoid, so it's below the arachnoid. Its severity is actually the most dangerous. It's extremely dangerous, and it's considered the worst type of hemorrhage. The presentation usually is a patient presenting with severe thunderclap headache, and the location of the bleeding occurs below the arachnoid mater. It's caused due to rupture of the congenital arterial aneurysm, or as we said or discussed, is the berry aneurysm, and its prognosis can be life-threatening with high death rate, as you guys can see here. This is a picture to show you guys the difference between subdural and epidural. It's important to know the images and the comment description of it. Now that we're done, here are some questions. The first one is a 50-year-old hypertensive woman complains of numbness and weakness in her leg and foot. Occlusion of which of the following vessels may account for this complaint? Please take a moment to pause this before you answer. So it's anterior cerebral artery. Second, last question. 79-year-old man is brought to the family practice office by his wife because he keeps running into things on his right side. His wife also reports that he seems to ignore objects on his right. Testing his vision in each eye, his physician determines that the patient cannot see anything in the right visual field of either eye. The physician orders a head MRI because he suspects which of the following: pituitary tumor, tumor in the medial wall, an aneurysm of the left middle cerebral artery, or a tumor in the middle cranial fossa, or aneurysm in the arterial supply. An aneurysm of the left middle cerebral artery compressing the left optic tract. With that, I conclude this PAL session. I hope it was helpful and beneficial. Inshallah, it helped you understand or memorize better the cerebrum parts and the blood supply. I urge you guys, or I encourage you guys to make mnemonics or stories that will help you understand this better and to always, always, always memorize the pictures. Memorize the pictures as much as you can. If you guys have any questions at all, please do not hesitate to contact me. I put my contacts here again. And please do scan this like QR code to send feedback to help يعني better deliver paths in the future, inshallah. Thank you guys for sticking in to the end of this path, and inshallah the exam is a breeze and الله يوفقكم يا رب يفتح عليكم ويسهل عليكم كل شيء. And that's it. Thank you guys so much and goodbye.